Hey everyone. Sorry, I think my computer had been on mute if anybody had been speaking.
Hi, I'm Yasi. I I don't think anyone was speaking previously. I just got let into the meeting.
Okay, perfect. And thank you for joining us to speak today. Um, I see Dan is also with us.
Yes. Hello,
Who did?
everyone. Thanks for coming. I guess maybe just a quick introduction for my friend and colleague here, Dr. Xiao. She's one of the assistant professors at Jefferson University, Advanced Endoscopy. She's going to be talking about lumen-opposing metal stents, so the big stents that we're using in our unit now, and sort of the utility of where things are currently and where things might progress down the line in the near future. I'll let you take it away whenever you're ready, Yasi.
Okay, perfect. All right. So let me just hold on 1 second. Okay, are you able to see my screen?
Yep, you're good.
Okay, perfect. And you can see my slides advancing, correct?
Yep.
Yeah, well, it looks like it's working.
Okay, perfect. So hi everyone. If we don't mind, we can just get started. My name is Yasi Xiao. I'm one of the advanced endoscopists at Thomas Jefferson University Hospital in Philadelphia in the US. I did my GI training actually at the University of Toronto, and I actually had the pleasure of rotating through Scarborough as a GI resident. And I have very fond memories of my time there. So currently I'm practicing as a advanced endoscopist at Jefferson, where my main focus is pancreatobiliary work. So today I'm going to be talking about the utility of lumen-opposing metal stents, also more commonly known as LAMS. These big metal stents and how we have been using them, as well as any new frontiers that they might be helpful for. So for those who may not be familiar, lumen-opposing metal stents have really revolutionized our management of a wide variety of GI diseases in the last decade. And these on the bottom left here, you can see that these metal stents are basically dumbbell-shaped metal stents of varying sizes. And because of their dumbbell structure and their fully covered nature, they allow for endoscopic luminal drainage by bringing two structures very close by to each other. So in this example here, we have a intestine and a abscess cavity that's being brought close together. And as the stent opens, whatever liquid in the abscess cavity will drain preferentially into the intestine. And they're commonly deployed under endoscopic ultrasound with or without fluoroscopy. So I'm going to be taking you through a couple of different uses of these LAMS stents in different variety. So first, I'm going to start talking about two FDA-approved indications with peripancreatic fluid collection as well as gallbladder drainage in non-surgical candidates. And then I'm going to talk briefly about how we've been using them widespread for gastroduodenostomy bypass, for gastrooutlet or duodenal obstructions, as well as biliary drainage. We do commonly use LAMS to access altered anatomy, such as blue and white gastric bypass, into the excluded components. However, I'm not going to touch too much on it just because I know that bariatric surgery is probably a lot more widespread here in the US compared to Canada. And then lastly, I want to talk to you about some novel stuff that we're doing here at Jefferson with creation of coloenteric bypass for malignant small bowel obstructions. So first, let's talk about drainage of peripancreatic fluid collections. I have a case here of a 33-year-old male with a recent hospitalization 4 weeks ago with necrotizing pancreatitis, who is now presenting with nausea, bloating, and fever, and CT showing a 10-centimeter walled-off necrosis within the abdomen. So off the bat, this patient has a infected walled-off necrosis that required drainage. As you may recall, here's the classifications. We have different types of peripancreatic fluid collection, pseudocyst, where it's mostly fluid, or walled-off necrosis, where it's mostly solids. And, we can have kind of a spectrum that exists in between with both liquid and solid component. There is a wide variety of drainage and debridement methods for walled-off necrosis and pseudocysts that's kind of transformed over the last couple of decades. In the past, we used to do open surgery with surgical necrosectomy, where there was a high mortality and morbidity. In the last 1 to 2 decades, we with the advent of interventional radiology, and as well as minimally invasive surgery, so like laparoscopy, we have transitioned to IR-guided percutaneous drain, and if needed, they can perform a surgical necrosectomy via the percutaneous tract called VARD. The problem with that is that with a percutaneous drain, there's often a lot of patient discomfort, and they have a high incidence of persistent enterocutaneous fistula after the drain removal of pancreatic juice. So when the last 15 years, so 10 to 15 years, we've kind of moved away from percutaneous drain into cysgastrostomy with either plastic stents or metal stents. And today I'm going to talk to you a little bit about why metal stents are actually kind of our preferred way of draining these peripancreatic fluid collections. So LAMS really allows for the creation of a easy gastrostomy for symptomatic peripancreatic fluid collection. With the advent of LAMS, it allows us to place a stent from the stomach into the pseudocyst or walled-off necrosis with a very high technical success rate of up to 95% and a high clinical success rate with a resolution of collections up to 84 to 98% of the time. The adverse event rate is low, with a small 2 to 3% risk of bleeding, 6% risk of migration, 4% of stent occlusion, and less than 1% of perforation. So overall, a safe procedure. And why is it preferred? So, if we look back in the 2010s, there were 3 landmark studies that came out comparing 2 groups. One is the percutaneous drain group with a possible step up to the minimally invasive surgical necrosectomy that we talked about, comparing with the second group with endoscopic management with cysgastrostomy with LAMS. And there was also a meta-analysis that was published kind of summarizing all 3 landmark trials. They found that there was no difference in mortality or bleeding risk between the 2 groups, and there was a similar success rate of collection resolution. However, the endoscopic group had significantly less number of patients with multi-organ failure, less risk of perforation, and a very, very much lower risk of enterocutaneous fistulas. The patients also had a shorter length of stay, as well as a lower cost, with a difference between $13,000 to $25,000 per patient, depending on which study you look at, per patient. And when we look at these patients over long term, long after the collection has gotten better, there was an extension study of the detention study where they looked at a 7-year follow-up for the same patient that participated in the study. Again, they found that there was no difference in complication or death between the 2 groups. However, even 7 years later, there was still a higher fistula rate formation and higher reintervention rate for the percutaneous and minimally invasive surgical group. So this is really important because, as you guys may recall, enterocutaneous fistulas have such a big impact on these patients' quality of life. A lot of times the patients with necrotizing pancreatitis are young and healthy, and they don't have significant comorbidities other than this pancreatitis issue. So they could be living with this ongoing cutaneous fistula, impacting their quality of life for years while they're trying to go back to school, go back to work. So it really is quite miserable for them. The other thing, that I think it's important to note, for walled-off necrosis, LAMS really has an advantage compared to percutaneous drain. It's because it allows for direct necrosectomy with direct removal of necrosis. So in this patient, he underwent a cysgastrostomy of a LAMS placement. Here you can see the picture of the endoscopic ultrasound window. And as soon as we placed it, we were able to get a large amount of black necrotic fluid back. And a week later, we went through the LAMS to perform necrosectomy with removal of solid necrosis. And we were able to have complete resolution of this fluid collection after 3 weeks. And we were able to remove the LAMS completely. And the patient's been doing very well afterwards. Now we're going to switch gears a little bit to gallbladder drainage. Here we have a case of an 83-year-old female with advanced dementia who presents with fever and altered mental status. She was found to have an elevated white count and cholecystitis due to a cystic duct stone. She was seen by surgery, and they recommended no surgical management due to her comorbidities. She was started on IV antibiotics for 2 days, but despite IV antibiotics, her white count had risen to 30 with ongoing abdominal pain. So in this scenario, in a non-surgical candidate, where cholecystectomy is not being offered by the surgery team, the standard of care has traditionally been a percutaneous drain. However, as you probably know as well as I do, that this is a significant challenge in patients that are older, possibly with dementia, where they could pull out the drain. There's a high risk of drain dislodgement, and there's a lot of discomfort within the percutaneous drain associated. So in these patients, gallbladder drainage with LAMS is a really good alternative viable option. What we do here, instead of putting a percutaneous drain into the gallbladder, is that we can place a LAMS from the intestine into the gallbladder, and allow the gallbladder to drain directly into the small intestine, thereby preserving the natural flow of bile into the intestine, and the patient has no external drain, nothing that they can displace physically, even if they're altered mental status. Now, what is the indication of a gallbladder LAMS? So the indication will be acute cholecystitis in a non-surgical candidate, or if the patient had already placed an internal a percutaneous drain and they are miserable, they are at constant risk of pulling it out, gallbladder LAMS can also be utilized to internalize that percutaneous drain with eventual removal of the percutaneous drain. We do have a couple of contraindications. So if the patient has a gallbladder perforation, if there is significant coagulopathy that cannot be corrected, a large amount of ascites between the gallbladder and the target with the stomach or the intestine, where the ascites can theoretically get infected or pull apart our two targets, or if the patient's unable to tolerate sedation due to a cardiopulmonary comorbidities. So gallbladder LAMS has also a very high technical success rate of up to 95% and an excellent clinical success rate of 94%. The risk of adverse events from a procedural related point of view is very low, about 5%, and could include bleeding, stent migration, or aspiration pneumonia or infection from the sedation itself. One of the advantage, kind of similar to how we're able to remove solid necrosis from a cysgastrostomy, is that if the patient has a lot of biliary stones within the gallbladder, in the future, we can also go through the LAMS and break up the stones within the gallbladder to decrease any biliary events. Now, I think the question that we have to be asking is, when do we choose percutaneous approach with a drain, and when do we choose gallbladder drainage? So in recent years, there's been a lot of studies comparing the two. And when we look at gallbladder internalized drainage with LAMS, both in our randomized control trial as well as in meta-analysis, gallbladder LAMS drainage has superior outcome when compared to a percutaneous approach. The two approach has a similar immediate technical and clinical success rate. However, in a randomized control trial, we found that the adverse event rate with a LAMS was significantly lower at 30 days, with 12.8% in the LAMS group versus up to almost 50% in the percutaneous group. Again, at 1 year, there's a significantly higher number of adverse event rate, up to 77% in the percutaneous group versus 25%. And these adverse events was really driven by the rate of recurrent acute cholecystitis, recurrent need for admission or reintervention. And when you look at the numbers, it's because in this randomized control trial, there was a significant number of patients that suffered tube dislodgement at 30 days and 1 year. So when it comes to, preventing recurrent events, gallbladder LAMS is far superior at 30 days and at 1 year compared to the percutaneous approach. In a meta-analysis looking at both RCTs as well as retrospective data, again, there was a lower rate of adverse events in the LAMS group at 1 year, around 17.9%, as well as compared to the percutaneous group at around 34%. Again, we're seeing a similar trend where it's really driven by the number of reintervention and recurrent cholecystitis. So the takeaway here is that gallbladder LAMS is the choice to go if the patient's preference is to avoid recurrent cholecystitis and reintervention. Now, the important caveat here is gallbladder LAMS drainage in a patient that's not a current surgical candidate, but maybe one in the future. The practice is very location dependent. Depending on your local practice pattern, some surgeons may not want to operate with a gallbladder LAMS in place. So if there's uncertainty about the surgical candidacy in the future, it's important to have a discussion with your surgeon. Now, if you're not sure, you can always place a percutaneous drain. And if the patient is no longer a candidate in the future, that percutaneous drain can be internalized into a gallbladder LAMS for patients' quality of life and comfort. So in our patient, where she had advanced dementia and altered mental status, she was at very high risk of pulling out a percutaneous drain. So after discussing with the patient's family, it was decided to place a US-guided gallbladder LAMS with plastic stents through the LAMS instead of a percutaneous drain. And here you can see the picture where as soon as we placed the LAMS, there was immediate return of pus, and the patient felt significantly better and with an improvement in weight count within within about 2 days. Now I'm going to switch, gear a little bit again to talk about US-guided gastrojejunectomy, where it's a bypass procedure. So here I have a patient with a 63-year-old female with metastatic neuroendocrine tumor of the ileum with mets to the peritoneum. She's actually undergone multiple surgeries in the last 5 years for debulking. She had a right hemicolectomy, and now she presents with nausea, vomiting, and a gastric outlet obstruction. And CT, as you can see here, shows the dilation of the stomach and the proximal duodenum. The NG she had placed an NG tube for decompression. She was seen by our surgery team, but because of her metastatic nature, as well as the multiple surgery, they had asked us to do a US-guided gastrojejunectomy. So what is a US-guided gastrojejunectomy? So as I kind of alluded to a little bit earlier, the LAMS stents really allows us to place any two closely placed structures and connect them and create new anastomosis. So similar to creating an anastomosis between the gallbladder and the intestine, here we can actually create a new anastomosis between the stomach and the small intestine. And as you guys are probably well aware, in patients with malignant gastric outlet obstruction or duodenal obstruction, these obstructions have a significant impact on their nutritional status and often prevent them from starting chemotherapy, whether if it's neoadjuvant or chemotherapy alone. In the past, we used to do enteral stenting with duodenal stents. However, these can be problematic when they remain in situ for about 3 months because they often suffer tissue ingrowth or food occlusion of the stent. An alternative would be a surgical gastrojejunostomy bypass, but a laparoscopic surgery, even if it's laparoscopic, can carry very high morbidity and mortality in patients that are already nutritionally deficient. So EUS-guided creation of the gastrojejunostomy allows us to place a connection between the stomach and the intestine under ultrasound guidance to allow the fluid to bypass the area of obstruction in the intestine right here. A contraindication, again, would be uncorrected coagulopathy if the patient's unable to undergo sedation or a large amount of ascites. US-guided gastrojejunostomy bypass has a very high technical and success rate of over 90% and an adverse event rate of up to 12% in meta-analysis. When we compare gastrojejunostomy with LAMS compared to duodenal stenting alone.
Hi, Tammy. Hi, I need the HST number, not GST number.
There is a
See?
What? There is.
Oh, sorry. Could everyone make sure their mics are muted for the rounds? Thanks.
There was a significantly lower rate of recurrent obstruction with a gastrojejunostomy compared to duodenal stent, with a odds ratio of 5 for adverse events with recurrent obstruction from enteral stenting group. And when we compare it to surgical gastrojejunostomy bypass, both in retrospective data and in a randomized controlled trial, the clinical success rate is similar, but as I'm going to tell you about in the next slide, endoscopic approach actually has a bit of a superiority here, where the patient's able to resume oral intake earlier, thereby leading to a lower cost and a shorter length of stay. So in a randomized controlled trial that was published in 2025, 74 patients with malignant bowel obstruction was randomized to either endoscopic or surgical gastrojejunostomy. And we found that the patient that underwent surgical bypass were more likely to still only be tolerating liquid diet compared to solid at discharge, and they were more likely to need additional reintervention or nutritional supplementation compared to the ultrasound group. The endoscopic group was found to have an earlier resumption of solid diet, a way shorter procedure time of 25 minutes on average compared to 111 minutes, shorter duration of hospital stay with 3 days in the endoscopic group and 9 days in the surgical group. And the endoscopic group was reported significantly better quality of life metrics, and the cost was approximately $20,000 less in the endoscopic group compared to the surgical group. And both groups had similar number of adverse events. So in patients that are newly diagnosed or in the midst of treatment for chemotherapy, they're often very anxious to get back to their treatment, and US-guided gastrojejunostomy may provide a better avenue for these patients to resume their chemotherapy and treatment sooner with less time that's nutritionally deficient with a better quality of life. In our patient, she underwent a US-guided gastrojejunostomy the day after presentation with a 20mm LAMS. She was observed as an inpatient, and I initially wanted to keep her overnight, but she really wanted to go home. So after observing for about 6 to 8 hours after the procedure, she went home, resumed oral diet with liquid diet initially, and advanced to solid diet the next day. And she did very, very well. She was seen in clinic 3 months later, and then again a year later without any recurrent gastric outlet obstruction. So here, this is kind of like a prime example of how quickly we can resume these patients on nutrition back home for a, almost essentially an outpatient procedure. Next, I'm going to talk a little bit about how we can use LAMS for biliary drainage as an alternative for ERCP. We have a case here with an 85-year-old man with pancreatic mass causing a distal biliary stricture with biliary obstruction with a bilirubin of 500. Now, unfortunately, he had also a duodenal stricture from a pancreatic mass, and we were unable to cannulate the papilla. In this case, EUS-guided LAMS placement provides a very good alternative for ERCP when ERCP is not technically feasible, either due to obstruction or unable to cannulate due to anatomy. There are some people that advocate EUS-guided biliary drainage as primary drainage, but this is really not yet mainstream in most places that, I've trained at. EUS-guided biliary drainage with LAMS has a very high technical and clinical success rate of more than 90% with a low adverse event rate of 7%. When compared to traditional ERCP, in 2 randomized controlled trial, it's at least non-inferior in terms of technical success rate with similar stent patency rate at 1 year with similar adverse event rate. In one of the randomized controlled trials, there was actually a higher technical success rate in the endoscopic ultrasound approach compared to the ERCP group. However, it's important to note that, in some practice, in some locations, if the patient is a surgical candidate, you should talk about it with your surgeon prior to placing the LAMS because it could theoretically make the surgery more difficult, but this is absolutely not a contraindication because multiple patients within these randomized controlled trials were able to proceed to curative resection with their pancreatic mass afterwards. It's also important to note that with EUS-guided biliary drainage, we are basically avoiding the risk of pancreatitis because we're not going near the papilla. So this might be a preferred use if there's a high concern for pancreatitis. After discussion with surgery for our 85-year-old gentleman, he was not a candidate for Whipple procedure, and we elected to perform EUS-guided biliary drainage with a 6mm LAMS, and bilirubin normalized, and he was able to start chemotherapy 2 weeks later. Lastly, I want to kind of bring your attention to some of the future directions that LAMS can provide us for palliative options for patients with malignant bowel obstruction, as well as other things. So as I alluded to earlier, LAMS really just allows us to make new connections between 2 closely located structures. So in this scenario, I'm going to tell you a little bit about what we've been doing the last couple of years here at Thomas Jefferson, but I do want to kind of, as a disclaimer, this is not at all widestream or widespread, but this is kind of a bit of a food for thought for everyone to kind of see the potential of LAMS in the future. So as you guys recall, our 64-year-old patient with the metastatic neuroendocrine tumor is back. So she no longer has a gastric outlet obstruction, but now a year later, she's presenting with nausea, vomiting again, and her EUS-guided gastrojejunectomy LAMS is very much patent, but now she has a distal ileum small bowel obstruction. Now, while she has metastatic disease, she has very good functional status despite everything. She's living at home. She doesn't have any other comorbidities. She has an ECOG of 1. So she's really hoping to continue treatment and get some good quality of life because after talking with her oncologist, her prognosis, if we can get the small bowel obstruction treated, would be probably in the span of 12 months to 24 months rather than weeks. So the 2 options here traditionally would be a venting peg tube. However, we decided to actually offer her a colon-enteric LAMS, meaning a connection between her colon and her small bowel, bypassing the distal ileum obstruction. So colon-enteric LAMS really is a way for us to treat malignant small bowel obstructions in patients that are non-surgical candidates. And we published a retrospective data on 26 patients from 2 centers where we performed coloenteric LAMS, and we were found to have over 100% of technical success rate and 92% clinical success rate of resolution of bowel obstruction. It does take a little bit longer compared to the gastroduodenostomy, where it takes about 6 days until clinical symptoms are resolved. In our study, 15% of the patients did have recurrent symptoms, but at different sites, which really kind of, speaks more to about the nature of these patients. They do have often advanced disease, and they could have other areas of obstructions that develop despite adequate bypass. The adverse event rate is higher compared to some of the LAMS procedure that I talked to you about, with up to a 15% rate of adverse events with diarrhea, bleeding, and sepsis. We are doing a new study here where we're looking at more patients that we've done since our initial retrospective study, where we've included 46 patients. The technical success rate and the clinical success rate remains very high, but we did find a significant number of adverse event rate, up to 40%, really driven by transient post-op sepsis. As you can imagine, we're going through the peritoneum with an unprepped colon. However, majority, over 85% of these adverse event rate was treated conservatively with antibiotics and resolved without any additional procedures. So in this patient, she actually underwent coloenteric LAMS from the sigmoid to the ileum in October of 2025. I saw her a month later, and she was eating solids with some loose stools, but improving overall. And I did speak to her just a couple of days ago in clinic again, and she had a great holiday over Christmas. She cooked her family their Christmas meal, and I'm really glad that we were able to give her a couple more months of good quality of life. And I think she's going to continue doing well until she has worsening progression of her disease. But this is, really a good possible viable options for these patients in the right candidate. So in summary, thanks to LAMS, we now really have a wide spectrum of endoscopic options that were previously mainly treated by percutaneous drains or invasive surgical management. And I think the take-home message here is I personally really do believe that LAMS is the preferred method of drainage for patients with peripancreatic fluid collection as well as non-operable cholecystitis. And the LAMS stents are also very excellent treatment options for small bowel or gastric obstruction. And I think it's really preferred and taken over from duodenal stenting or surgical gastroduodenostomy. LAMS can also be used for biliary drainage when ERCP is not feasible, and there may be roles for LAMS for other oncological palliative options in the future. Thank you very much for listening to this talk, and I will open up the floor for any questions.
Thanks for a super talk, Yasi. I had a couple of questions. Hopefully you can answer, I guess, the practices at Jefferson compared to what we do. It'd be great to compare notes just for each of these indications. But for peripancreatic fluid collections, mainly pseudocysts, are you using LAMS for all comers, or are you using cystotome with double pigtail plastic stents? So as you probably know, cost consideration is huge here in Canada. And so doing a cystosome with double pigtail stents is probably around 15% of the cost of LAMS.
Yeah. So when something is mostly fluid collection, you can really go one way or the other. The cystotome does take a lot longer and could theoretically have more steps go wrong. So we really still go by use lumen-opposing metal stents. But for a smaller collection where it's going to get resolved really quickly, double pigtails are definitely a viable alternative. But I do recognize the cost difference between the two. So I would say if you look with an endoscopic ultrasound, it's mostly fluids, you could definitely do double pigtails. But if there's a hint of solid debris within there, LAMS is better because it will really allow that solid stuff to flow out.
What is Jefferson's practice with regards to direct endoscopic necrosectomy with regards to timing? Do you guys do LAMS plus same session, or do you wait a couple?
Yeah.
Yeah, go ahead.
We don't do same session. We do wait usually about 2 to 3 days, and sometimes up to a week, just depending on how sick they are. If they are rapidly improving, we might just bring them back in a week, or just kind of re-image them in 1 to 2 weeks. Whereas if they're really sick, still has a high white count, intermittent fever, we bring them back in about 2 days and start performing necrosectomies on them.
Awesome. Could you speak to gastric versus transgastric versus transduodenal for gallbladder drainage, and when you would choose one versus the other, and whether or not there's been any issues from a surgical perspective depending on each of those modalities or routes of drainage?
So duodenal approach is preferred because there's less of risk of food occlusion and stent migration. However, that being said, if the patient is a possible surgical candidate, drainage through the stomach may be preferred because it's much easier for the surgeon to close a fistula from the stomach compared to the duodenum. But really, it's whichever one you get a safe window for ultimately.
I think our practice by and large at our facility is to put perc drains in for non-op gallbladders. I don't know if that's true across the site, but maybe someone from the other site could comment on that. But I feel like that's the main thing that's generally happening across our network.
Sorry, are you asking me?
Oh no, I was asking.
Okay.
But that's okay. From what I've seen, I think most people have been getting perc drains rather than EUS guided LAMS, like for gallbladder drainage, and I think the landscape has shifted such that, in my opinion, LAMS and gallbladder drainage is probably better compared to perc chole, and there's more evolving evidence from that regard as well.
Yeah, I think that percutaneous drain still remains the most common way of drainage across multiple institutions. But I do urge, in patients that are never going to become candidates, that are at high risk of pulling out the drains, to consider endoscopic drainage, because the risk of the stent dislodgement is just so much lower. The risk of recurrent cholecystitis is just so much lower, and the patient is so much happier.
I think there's actually a position statement from ASGE from Irani's group. I think he was the senior author on it, with the algorithm for how to treat non-op gallbladder cholecystitis, pardon me. And I believe that US gallbladder was sort of the first option if there weren't any contraindications.
Yeah.
Are you revising the gallbladder stents at all?
If they are able to tolerate one additional procedure, I do bring them back in about 6 weeks to pull out the LAMS to avoid any bleeding from the LAMS, and then I leave the double pigtails indefinitely.
Interestingly, before we get to Grant, there was a study in Europe that showed long-term indwelling gallbladder drains like LAMS for up to 3 years without significant complications. And so that's, for our sort of demographic where our average age is greater than the age of 90, that's probably something that we do in our particular practice.
Yeah, so I would say, especially if you're placing in the duodenum, you can definitely leave the LAMS in place forever if they're poor candidates for any sedation. But if you look at that 3-year study, I think they had a survival curve for recurrent stent occlusions, it kind of goes up over time. So I would say if they're well enough to tolerate one quick EGD, you can just pull out the LAMS and you can leave the plastic stents in. Often can remove the LAMS over the existing plastic stents in to just kind of avoid any additional, complications. I think Grant had a question, or at least a hands up.
Not so much. Well, a question for Dan. Do you think you're gonna change the institutional practice? And if so, are you gonna win the lottery to do so?
I think we should 100% be moving toward this practice. We have funding both from research as well as we have funding available to accommodate these cases for the number of patients who have undergone per cholecystostomy tubes. We're able to cover that volume via research or via another mechanism.
That's great. So, are we going to see this shift then soon?
I think Brian and I would be more than happy to do more of these cases. As Yasi mentioned, even if these patients get a percutaneous cholecystostomy tube at a different site, we can revise these after a couple of weeks safely from a quality of life perspective. I think the other piece is speaking with our surgeons as well in terms of creating an algorithm and protocol for how to best manage non-op gallbladder disease. Yasi, could you speak to the durability of EUS GJ versus surgical GJs? When I was in the US, we would always ask our surgeons to be involved for a surgical GJ with the theoretical benefit of less likelihood of reocclusion and so on and so forth. Could you speak to maybe that?
I mean, we always get our surgeons involved before doing anything because we work very closely with our surgeons. Like I spend all morning on the phone with different ones for different patients. But I would say durability-wise, like we've left these LAMS in place sometimes in patients that are poor surgical candidates for up to 5 years. And I think that we do sometimes, depending on the patient's clinical status, and I don't think there's a set guideline here. We do kind of sometimes go in at 1 year to look at the LAMS to see if there's any tissue ingrowth. And if there is, can pull it and put a new LAMS in. There are novel strategies to kind of suture the gastrojejunostomy site to eventually remove the LAMS with endosuture, but I don't think we're doing that widespread.
And do you think there's any utility of, so for us, an EUS-GJ is a fairly large procedure at our institution. Do you think there's any role for duodenal stenting as a bridge to considering EUS-GJ? Like that's always a far easier route for us rather than a direct procedure.
I would say, I think the more that you do, a gastrojejunostomy becomes more like easy and straightforward. And unless you know that the patient is going to go for like surgery within the next 1 or 2 weeks and just want to put the duodenal LAMS in, duodenal stent in for decompression, I will probably just go for the gastrojejunostomy. A duodenal stent really doesn't have that much benefit, and I'm not sure the utility of placing a gastrojejunostomy after a duodenal stent, because then you're just kind of revising that duodenal stent going forward. I would say, gastrojejunostomy has a low enough adverse event rate that I would think that it's probably better as a first line.
Thanks.
Okay. Well, thank you so much for having me, you guys. I look forward to, chatting with anyone. If you have questions, I can put my email down here. And if there's any questions at all, happy to answer them. But I think you guys have an excellent group there. And I know Dan is doing some really exciting things within this group to kind of, advance the GI care at Scarborough. So. Have a great rest of your day, guys.
Thank you, Yasi. Thanks for presenting.